However, you got to watch out for the anticoagulant therapy because heparin can lower antithrombin levels. And really to get a clear view of, if your antithrombin is low, to get a clear view of is this heparin or not, is you want to wait at least 5 days after cessation of therapy. And warfarin, as you're all aware, is a vitamin K antagonist, so the levels of the vitamin K dependent factors 2, 7, 9, and 10 go down, but also protein C and protein S. So it really, if you want to exclude protein C or protein S deficiency, it's not good to do when somebody is on warfarin therapy. It's best to do it after cessation of therapy. And the recommendation said 30 days because some of the warfarin formulations that they use in Europe have a much longer half-life than the Coumadin that we use in the United States. And you probably don't have to wait 30 days in the US. Now, there have been several papers published of how do you look for protein C or protein S deficiency in a patient who's on Coumadin. Can you do it by doing a ratio of protein C activity to, say, factor 2 or to factor 7? Yeah, you probably can, and I know there are some reference laboratories that do this, but the data isn't really good that there isn't some sort of crossover with this, and I really think it's best to do the testing to try to exclude these when the patient's off of warfarin therapy. So typically with warfarin, both C and S go down kind of the same. So if you're on somebody, you know, warfarin and their INR is like 2.5, your protein C may be 30, your protein S may be 35. If they're both down about the same, chances that they have a protein C or S deficiency are very small. But if you've got somebody whose protein C is 30 and their protein S is 5, you know, that does suggest that there could be additionally a protein S deficiency. Doesn't prove it. You still would want to do the testing later. So let's look at another case. Case number 6. 44-year-old female hospitalized with a right lower extremity, DVT. Her pro time is 10 seconds. Her PTT is 58. Her protein C and protein S are normal. Her antithrombin is decreased. Her factor V Leiden and her prothrombin are negative. Well, you know, here she is hospitalized with a DVT and her PTT is 58 seconds. So the first thing I think about, because if we get a sample from a hospitalized patient with a high PTT, it's, you know, guilty until proven innocent, I think. So it's heparin until you prove otherwise. So we would screen the samples for heparin, and there are a lot of different ways to screen hypercoag samples for heparin. You can do a thrombin time to pick up heparin. The nice thing about thrombin times is that they also pick up direct thrombin inhibitors. So, and we're seeing more and more use of direct thrombin inhibitors. In this case, we did a heparin assay, a heparin anti-10A assay that came out positive. We don't stop there. We actually neutralize the heparin activity. We treat them with Hepadsorb. There's Hepzyme. There's a lot of other ways to get rid of heparin or neutralize it. And after we treat it with Hepadsorb, we always remeasure the heparin assay, make sure that we've gotten rid of the heparin, and then look to see what happens to the PTT. We've had several patients, and we probably get a couple of these a week, that actually are on heparin and have a lupus anticoagulant. And in those individuals, say their PTT would be 58 seconds, they've got positive heparin, you get rid of the heparin and their PTT may still be 50 seconds. If you see that, then you could go and do lupus anticoagulant testing. But I like to do the heparin assay afterwards just to make sure we've gotten rid of the heparin. In this case, I wouldn't pursue it any further since the PTT normalized after we got rid of the heparin. So with this one, the moral is really to screen for heparin when you have an elevated PTT. And again, a decreased antithrombin, like the last case, can be seen with heparin and during an acute thrombosis. Now, as far as the DNA-based methods, like for the prothrombin mutation or factor V Leiden, it honestly doesn't matter when you do these. You can do them in acute phase response, you can do during acute thrombosis, because it's a DNA-based method. The levels of these, you know, the mutation doesn't change based on any therapy or disease processes. So since these are DNA tests, they can be performed while the patient's on anticoagulant during the acute phase, et cetera. Now, as far as antithrombin, some of the functional assays, the natural anticoagulants we'll be talking about, you can do functional and antigenic assays for these. And it's really recommended that you start with the functional assays. Typically, the antithrombin assays are amylolytic or chromogenic. There are some clot-based assays. out there, and these are really recommended for initial testing for the antithrombin deficiency because they'll pick up true deficiencies, but they'll also pick up dysfunctional mutations of the protein. Typically, there's really no need to do the antithrombin antigen assays. If you identify a functional antithrombin defect, unless you really want to do family studies, do research, they're not going to treat those patients any differently if they have a true antithrombin deficiency or dysfunctional protein. So there's really no reason on a routine basis to do this. Keep in mind, though, as we've discussed, that heparin can give you low antithrombin levels. L-asparaginase therapy can give you low antithrombin levels. Antithrombin's made in the liver, so hepatic dysfunction will give you low antithrombin. It goes down like crazy during DIC. So one of the things as far as looking at antithrombin deficiency is an isolated defect in antithrombin. So if you've got low C, low S, low antithrombin, low fibrinogen, you're probably talking DIC or liver disease, not a congenital deficiency. And I get very frustrated at the panels that we get coming from the medical intensive care unit for thrombophilia workups. Because by virtue of being in the medical intensive care unit, over 50% of the patients probably have a consumptive coagulopathy. Most of them have liver disease. And you just get these massive abnormalities of thrombophilia testing. So trying to fend these panels off takes a fair amount of time. So let's kind of look at an algorithm for protein C testing. So let's say with protein C, again, you start with a functional assay like a chromogenic or a clot-based assay. If that's normal, you stop. If it's low, then you got to start looking at some of the other lab parameters. Are the patient's ProTime and PTT normal? Well, no, if they're not normal, then you want to think about maybe looking at their liver function tests. Or their fibrinogen level, or look up the medical record and see, is this patient on warfarin? And most of the time, a low protein C with a high ProTime or PTT is probably warfarin until proven otherwise. So if you've got somebody who's on warfarin, their liver function test should be normal, fibrinogen should be normal, D-dimer, antithrombin should be normal, and protein S should also be abnormal. Whereas with DIC, you should have low levels of fibrinogen, very high D-dimers, low antithrombin, as well as low protein S. So in general, if you've got somebody, maybe their warfarin was stopped recently, then you probably want to repeat the protein C when they're a little bit further out. If not, then you want to repeat your protein C activity, maybe measure protein C antigen to try to distinguish type 1 from type 2. Protein C deficiency. Type 1 is a true deficiency in both the antigen and the activity. Everything's low. It's probably a gene deletion. Type 2, if there's a point mutation, the activity may be low, but the antigen, the amount of protein there may be normal. You want to confirm the deficiency on a new sample before you call somebody congenital protein C deficiency. And this is an algorithm that from a chapter that Chuck Eby wrote. It's a textbook that the CAP COAG committee it has developed. We actually just submitted the manuscript about 2 weeks ago. It'll be an algorithmic-based approach to hemostasis testing because there really aren't many laboratory-based books on COAG testing.